Yeah. Yeah, I have shared my screen. Yeah.
Okay, I guess we will start. Yeah. Good evening, everyone. Respected Dr. Vivek sir, members of the Safe Dental Updates, and dear doctors. We welcome you back for our 46th episode of Learn from Our Master series organized by Safe Dental Updates. And it's a beautiful journey so far. And I thank all the doctors who are attending our webinars so far and also visiting our platform like our Instagram, our YouTube channels. And we are very humbled to see your positive feedbacks. So for those attending for the first time today, I would like to do a little bit of introduction. So we are Safe Dental Updates, a dental platform in which we believe quality education always ensure predictable outcome for dentists of all disciplines and abilities. Our organization is established based on observation that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide a dental journey. So without further ado, let us start our series in which our topic of discussion is rescuing the trapped. What is the best predictable technique for file retrieval? Given by Dr. Vivek sir. So I would like to invite Dr. Vivek sir for today's discussion. Sir, please.
Okay. Am I audible?
Yes, sir.
Okay. Hello, everyone. I can see some of my friends are also online. So, as we step into the new year with an excitement and anticipation, I would like to wish everyone a happy and prosperous new year ahead. I'm so thrilled to give this first webinar of the year on this Safe Dental Update platform. Special thanks to the Safe Dental Update teams for making this possible. And a huge shout out to their dedication in keeping us all updated on cutting edge advances in dentistry. Coming to the topic, so why am I calling it rescuing the tabbed instrument? Isn't it we are trapped in a clinical situation when a file tries to play hide and seek within the kennel? Should we attempt to retrieve, or should we bypass, or should we extract? How to tell the patient? How to convince the patient for further treatment, etc., etc. So don't get offended, doctors. I would still call it rescuing the trapped instrument, not the doctors, because I strongly believe file fracture is iatrogenic. It occurs either we are not respecting the canal anatomy or we are not following the most basic principle of endodontic practice. So before starting this webinar, let us know how not to fracture a file. Myself, Dr. Vivek Mahale, I have finished my BDS from a course Davangere, and I'm currently pursuing my MDS from Savita Dental College, Chennai. So coming to how not to fracture a file, basically there are two mechanisms of file fracture. First is flexural fatigue and second one is torsional fatigue. Don't worry, we don't get all tangled up in jargon of terms and definitions. So keeping it simple, fractional flexural fatigue is also called as cyclic fatigue. It is due to repeated compression and tension of the instrument at curved canals. So if you see at this if you see at this curvature, the file in the outer curvature, it is always undergoing a flexion, and the inner curvature, it is continuously undergoing compression. So the file is undergoing repeated bending, which will weaken this file before it snaps. So whereas the torsional fatigue, it occurs when the tip or any part of the file is stuck within the canal and the shaft continues to rotate. So larger diameter files usually give up by flexural fatigue, while smaller diameter files give up by torsional fatigue. And this torsional fatigue can also occur in straight canal. So let's see how not to fracture a file by mastering the art of overcoming flexural and torsional fatigue. First and foremost, as we all know, the basic objective of access cavity is to get a straight line access to the apex of the canal. or at least till the first curvature. So this reduces the flexural fatigue on the file. But nowadays we have operating microscopes and various advances in NiTi files. So this makes a clear shift from conventional access cavity to a selectively tapering access cavities. So as a next step, you should always prepare a smooth tunnel-like preparation from orifice to the apical constriction. This is called as glide path, which should be done with 15 or 20K files. This glide path, which it will guide the non-cutting tip of rotary NiTi, and it will guide the rotary NiTi without any obstruction. And then it's very important to enlarge the canal using orifice enlargers. So this not only reduces the contact with the walls, but it also reduces the initial coronal curvature of the canal. So no need to mention the maximum caution should be taken while negotiating through calcified canals, long narrow canals, aberrant morphologies, etc. So there is increased chances of file fracture in cases of molars as compared to premolars and anteriors. And it is also in the mesiobuccal canal of both maxillary and mandibular molars. These chances of file fracture will increase when the angle of curvature is more than 30 degrees. And also interestingly, these chances increases when the curvature is in coronal and middle third rather than apical third. So we should always assess the preoperative radiograph before starting the case, and we should always select right file system for the case. When we talk about right file system, there is a continuous research is going on in this area with newer technologies coming in every day to make files more flexible. So files made up of M-wire technology, CM-wire technology, blue-wire technology, EDM files, these are all more flexible and more reliable when negotiating through the curved canals. So such canals, in such canals, the files with lesser taper should always be used. Like in curved canals, you should always use lesser taper files. And one more interesting fact is that reciprocating files are known to fracture less as compared to conventional rotary files because they are not rotating at 360 degrees. In curved canals, I personally prefer Profit S3 rotary file system. So as it is heat treated and titanium coated, which makes it more flexible. So for narrow canals, we can use PF1 file, and for wider canal, we can use PF2 file. And then another most important reason for file fracture is wrong instrument motion. So we should always use files in continuous pecking motion, and it should not be held static in the canal. And this pecking motion should always given with very light apical pressure. So if you hold the file at static in one position, it will always lead to a stress concentration at one point. This will again lead to fracture of the file. Also, never force the rotary file in the canal. Then we should preferably use files only for once, or then you should keep on checking the files for any unwinding or bending. And always, you should always replace it once you use it in narrow and curved canal. Next is speed and torque. Speed of rotary files should be according to the manufacturer's guidelines. So if you increase the speed, the life of file will always reduce. And then coming to the torque, torque is the amount of force applied by the file on canal walls to overcome the friction by canals. So when a file is rotating in the canal, there is always a force acting against the file by that is the friction due to the canal walls. So torque is the force applied by this file to overcome this friction. So this is determined by the contact area between the instrument and the blades and dentin. So there is one important concept called as taper lock phenomenon. When you use instrument of same taper, but progressively larger size, the root canals larger size, there is excessive friction due to increased area of file with contact with the file with the dentinal wall. So to prevent this, we should always use two different tapers files to prevent this excessive torque on the file. For example, if we work with 24%, then we should shift to 26%, then 25.4%. So the friction on this file is reduced because of reduced contact area. So then comes the irrigation. So dry canals increases the file fracture due to friction. So irrigating solution should be used continuously after every filing to keep the canal lubricated. According to literature, liquid irrigants are proved to be more and better lubricating effects than the gels. So I would like to share you a story. So once my nephew was playing and he got his head stuck in the balcony grills. So he was continuously crying, and my sister is trying to help and had to free his head, but to no success. Then me, who has studied all the physics and biology, went into help and failed miserably. That time, the only one thing was coming to my mind was that, अरे यार, इधर से ही तो अंदर गया था, बाहर क्यों नहीं आ रहा है? So same thought came into my mind when I broke my first rotary file in the canal. It came in it went in the same route. It should come out very easily too. Do some irrigation and file will be out. But it's not as simple as that. Ease of retrieval is always dependent on the multiple factors. So let's see what are the factors that should consider before attempting the instrument retrieval. The first thing is visibility and accessibility of the file. If the instrument is visible in the canal, it doubles the chance of instrument retrieval. So it is very important to use operating microscope or at least loops with sufficient magnification. So while attempting the retrieve file, you should always use magnification. That is the most important thing. Then coming to the tooth type, posterior teeth they're having more complex anatomy, making it more difficult for file retrieval. That too, in the mesobuccal canal of the mandibular molars is most difficult to retrieve as compared to maxillary teeth. So next factor is type of the instrument. So NiTi files they undergo secondary fracture more often than stainless steel files. So this is due to the cyclic fatigue caused by continuous ultrasonic vibrations. Whereas stainless steel files absorb this energy bodily and they just pop out of the canal. NiTi files in austenitic form are they tend to fracture more frequently than martensitic files. This austenitic file, they always pressing against the outer curvature of the canal, curvature of the canal, so making it more difficult for instrument retrieval, and it takes more time for preparatory stages. In a study by Fuad et al., it was concluded that fragment longer than 3.1 mm and canals with curvature required more time for instrument retrieval. So fragments longer than 4.5 mm require double the time of that of fragments lesser than 4.5 mm. So all of this means is that more the length of the file, more difficult will be to retrieve. And also with increased length, there is increased incidence of secondary fracture also, as we all know. Then comes the location of the instrument. We all know there is a very low success rate of retrieval of instrument fracture beyond the curvature. So when the file fracture is beyond the curvature, the retrieval success is always less. Then instrument retrieval from these curved canals is a humongous task. So that too when the curvature is greater than 20 degree. The success rate almost drops to half when the curvature is greater than 20 degree. So either if you see most of the times these canals will be curved, not at all, not in the same single plane. They will be curved in the multiple plane. So either we'll not be able to get a straight line access to the fragment, or we'll have to remove a lot of denting to reach the file. Then we better not attempt the file retrieval when thickness of dentin around the file is very less, or when there is increased depth of increased depth of concavities around the root, which makes it more prone to strip perforation. If the file is broken in initial stages of the treatment, its treatment plan will be differ than the file broken in later stage of the uh, preparation. As in initial stages, we have not removed all the necrotic debris and all the bacteria, and the canal is not completely disinfected. So this factor is also you should consider. Then action of the file is a file you should consider, because when you use ultrasonic for retrieval, you should always use this against the motion of the file. So if the file is used in clockwise motion, you should use the ultrasonic tip in anti-clockwise motion. And one more thing is operator fatigue and experience. So the instrument retrieval attempt should be around 45 to 60 minutes. And as the time increases, the success rate drops, maybe due to the operator fatigue or maybe because of procedural errors also. And last but most important thing is patient's willingness to undergo the file retrieval treatment. Sometimes patient might be anxious, and he might not be willing to sit on the chair for so long, as so they might be opt for obturation or even extraction. So when patient says no, it's always a no. Don't intervene. So here one question arises. That is it absolutely necessary to retrieve all the instrument you see in the canal? So friends, you might have to free all the heads stuck in the grills, but you don't have to free all the instrument trapped in the canals. So when you don't have to retrieve the instrument trapped in the canal, first thing is when there are two absolute contraindications for file retrieval. That is when the prognosis of the teeth is hopeless, and the teeth is very mobile and periodontally compromised, and it is non-restorable at all. Then second one is when there is no clinical or radiographic sign of pathosis. So a patient comes to your clinic for a treatment of adjacent tooth, and while taking radiograph, you might see a fractured file obturated nicely with in the adjacent teeth, obturated nicely with a file inside. So if you see such teeth, if there is no clinical symptoms and if there is no radiographic symptoms, don't intervene. Okay, again the grill and the child. So what do you think? How many ideas are there to free the head from the grill? Okay, all like most of you are all thinking about cutting the grill, right? Yeah, that looks so easy. Okay, that is an option. Then next, what is the next technique? So what about separating the grills a little bit and then freeing the head? See how minimally he is freeing the head of that child. Okay, you might be wondering why I am so worried about that grill than her head. Okay, if you compare this, if you compare this child as the head as broken instrument and grill as dentin, uh, if you there are multiple techniques and kits available to remove these file successfully with very less dentin sacrifice. So if we don't know what are all the option available with us, we'll always be choosing the most easiest way, that is obturation with the file inside or extraction. Okay, there's one surprise. Did anyone get this technique in mind? No, right? So see how important it is to know all the options available before intervention. If you don't see this video, no one would know this was also an option. So let us see what are all the instrument protocols available for successful instrument retrievals. Before that, many people might be wondering, should we attempt to bypass first or should we attempt to retrieve first? As a rule of thumb, we should always attempt to retrieve first, and then if it is not possible, then bypass it. So coming to the instrument retrieval protocols, they are divided into three types. First is mechanical, chemical, and surgical. So chemical retrieval protocols, they include using of EDTA, which will decalcify the root dentin wall, which will help in subsequent bypassing or retrieval of the instrument. And second one is dissolution of metallic fragment by corrosion using iodine compounds, sodium hypochlorite, hydrochloric acid, sulfuric acid, etc. Then a novel technique, which is called as electrolytic technique, which uses saline, sodium hypochlorite, hydrochloric acid, and it uses two electrode which should be inserted into the canal or inserted into the canal to dissolve the file. These chemical techniques, other than EDTA, are not commonly used because it is time consuming, and also any chemical used in the root canal is always harmful to the periapical tissue. If you know, iodine compounds are known to stain the teeth. So chemical techniques cannot be solely used for instrument retrieval, but they can be used as adjunct to the adjunct, and they can be used as preparatory stages. So coming to the mechanical instrument techniques, they always based on two basic principles. So the first step you should do is staging. That is flaring the canal. That is flaring the canal coronal to the fragment and create a space. Flaring the canal coronal to the fragment and create a space around the instrument in order to free the coronal part. And then you will attempt, and as a second step, you will attempt to retrieve using appropriate technique. So these are the two basic principles followed in most of the mechanical instrument retrieval protocols. First, staging, then attempt to retrieval. Before that, we have to either take CBCT or radiographs in multiple angulation to reveal its file location in relation to curvature, length, etc. So there's a whole lot of advantages when you take CBCT. As you can see, if the file is against which wall, and if you can see any spaces there adjacent to the files, etc. And it gives a complete 3D visualization of the file in the canal. Then we should refine the access cavity to allow a better visualization and manipulation of the canal. One more thing you should not forget is to cover orifice with the cotton or Teflon. So otherwise, if file comes out jumping from one canal, and then if it goes to other canal, then the hide and seek continues. Sometimes when you are using ultrasonic to expose the coronal 1 to 2 mm of the file, suddenly we cannot see any metallic head there. So we are happy that file might have popped out. Then you do irrigation, and suddenly the file is there again. Okay, that file never popped out of the canal. It was the dentinal shavings or dentinal dust that was covering the file, so which was making it invisible. So the frequent irrigation and drying cycle should be followed for a continuous visualization of the file head. And you should and to keep track of surrounding dentin. And when in doubt, you should always take radiograph. If you feel like file is moving apically instead of coronally, or if you feel the file size might have got reduced, you should always take chuck X-rays to confirm. So first technique I would like to explain in mechanical instrument retrieval technique is ultrasonic. So again, the first step in retrieval using ultrasonic is staging. First, we will create a circumferential staging platform around the most coronal part of the file with modified GG drill, which should be used at a reduced speed of around 300 RPM. And then cross section of this modified GG drill should always be centered, and it should be larger than the diameter of the file fragment. This GG drill kept centered, and it should be directed apically till it touches the file head very slightly. And so by keeping it centered, we are minimizing the risk of strip perforation, and we are minimizing the removal of dentin. We are reducing the sacrifice of dentin. So if there is any curvature, if you can't use GG drill, you can use number 62% high flex EDM files. So EDM files to prepare the canal till the fragment. So as you can see in the picture, first step is to prepare the canal till the fragment. So once you have prepared the canal till the fragment using GG drill or high flex file, then next step will be to then okay, this is how the modified GG drill looks like. Okay, this is how the modified GG drill look like. You can prepare it by marking the tip, marking the head at the maximum diameter, and you can cut it with the diamond abrasive. So it's non-cut. By making this, its non-cutting tip is removed, so it becomes more aggressive. So you should always use this under the microscope only, or else it might cut more of the dentin, and there's also chances of strip perforation. You should always use this under continuous visualization under the microscope. Then, as a second step, we should expose the coronal 1 to 2 mm of the instrument using a pre-selected ultrasonic tip. For this step, I personally use the ED16 ultrasonic tip for this purpose. The trick is to trough the dentin around the file in the anti-clockwise motion with minimal power settings, like around 10 to 20% of the highest power setting. And you should avoid the diamond coated tip because it causes more dentin loss and it is more aggressive. So during this step, you should also take care not to touch the file, or to touch the file very minimally, or else according to a study, whenever the file is loose in the coronal segment and there is no supporting dentinal wall opposite to the area where the ultrasonic file is used, there is increased chances of secondary fracture. So in this stage, we are removing the dentin around the file circumferentially. So there is no any wall against the file in coronal 1 to 2 mm of the canal of the fragment. All of this step is done in a dry environment, and you should dry environment. So we should always keep in mind the heat generated by ultrasonic during their use. So you should always keep it as a short cycle of troughing and irrigation. So troughing and irrigation. Coming to the third step of ultrasonic retrieval, it is loosening the fragment. In the next step, small diameter tip is used to cut the 90-degree semicircular space in the inner wall of the curvature. So once you trough a 90-degree in the inner wall of curvature, you can extend it to 180-degree, going up to the depth of 1/3 of the fragment. And if you go to up to the 1/3 of the fragment, the file, there's more chances that the file might loosen. And if the file will not loosen, then you can trough a little more, and until the file gets loosened. If it is a straight canal, you should always trough this 90-degree and 180-degree semicircular troughings in the thickest wall that is seen in the CBCT. Next, fourth step is the retrieval attempt. So whatever we had done till now, first, second, and third step, it is all called as comes under staging. So now it is attempt to retrieve. So the preparation phase is considered complete once the file is loosened in the canal, when the file is moving. So now it's time for attempting the retrieval. So for retrieval, first the canal and access cavity should be fully flooded with EDTA, and here we can use more thinner ultrasonic tips like ET25. Now you can increase the power setting 10 to 20% from the initial power setting which we used for staging. Then this tip should be moved up and down in a pecking strokes in the inner wall of the canal. So then here the file floats out. This file will float out of the canal due to acoustic streaming and cavitation. So there is the successful instrument retrieval. So when do I prefer ultrasonic retrieval technique? So when the file is smaller than 4.6 mm, when the file is tightly bound in the canal, and when there is adequate thickness of dentin all around the file, and when it is a stainless steel file or short files beyond the curvature, I will always prefer ultrasonic retrieval technique. Then the second step is loop technique. Second technique is loop technique. So here we can prepare the loop by using a 25 gauge hypodermic needle and 0.414 mm diameter of the wire, and you can use a hemostatic forceps to tighten the loop when you engage the loop to the file. And there are several loop devices also available in the market, like most prominent ones being BTR pen and TFRK kit, etc. So in this loop technique, the first step again is staging and loosening of the file. So here we should at least expose 1.5 to 2 mm of the file, and we should loosen the file before engaging. And during the retrieval attempt, we can take a check radiograph if the file is if the loop is engaging around the file or not, before pulling the assembly and engaging the loop. So you can take a chuck X-ray and then engage the file with the loop and then pull it in the various direction. You should not pull it in the single stroke. You should pull it in various direction. You can see all the steps here. The first 4 steps are all the same. It is all the staging. Then the final step will be attempt to retrieval. In attempt to retrieval, we use a loop to engage the file in the canal and then pull it out. So there are several points you should consider before using loop technique. That is, if coronal segment is resting against the wall of the root canal, then we can use the endodontic explorer to loosen the and free the segment from the wall. Then one more thing is loop should be always oriented according to the existing space. If there is space along the distal wall of the canal, then loop is always oriented mesially, so that our needle will go into the space and loop will engage the file. Then you can bend the needle in whatever direction if there is accessibility or visibility issue, and this assembly should be moved in various direction and up and down motion. So I prefer this loop technique when the file is not coming out of the canal after retrieval attempt with ultrasonic technique, or when there is a long file which is loosely bound in the canal. Next technique is braiding method. So this is one of my most favorite technique. So in this, the first step will be preparation of the canal up to the fragment. Here we will not be using any ultrasonic to trough around the file. So first we will use the GG drill to expose the head of the fragment up to the head of the fragment. Then we'll do the retrieval attempt by bypassing 2 or more K or H files, and it should go at least around two-thirds of the total length of the file, and then all 3 files are wound around until the fragment is tightly grasped and the assembly is withdrawn in clockwise and anti-clockwise motion while pulling it out. So the factors you should consider while using braided method is K file is always better than H file, because as the H file, it can again bind to the canal wall and it can also again fracture. So I will always prefer K file than H file. And this file should not be loose. If you can see in this picture, the files which I have inserted for retrieval, it should be exactly fitting between the face of the fragment and the canal wall. Then the files which you use for retrieval should be engaged in 2 different phases. This is easier when we use magnification like microscopes or loops. And you should be always engaged in two different phases of the file. If you use in the same phase, then don't expect the file to come out. Fourth one is you should, while retrieving, you should rotate the assembly in a slight clockwise and anti-clockwise motion. So next step is the modified tube technique. This is the fourth. This is the fourth mechanical instrument retrieval technique. So here in this technique, the staging is done to expose the coronal 1.5 to 2 mm of the file. So first you will use GG to enlarge the canal up to the fragment. Then you will expose them 1.5 to 2 mm of the file. Then you should choose a needle micro tube which will exactly fit over this protruded head. So once you choose this needle which fits exactly over this protruded head, a pre-selected H file is pushed through the needle to wedge the upper part of the fragment. So once this upper part of the fragment is engaged, the assembly is pulled out as a whole in a slight clockwise and anti-clockwise motion. So this technique I prefer when the file is long and loosely bound and it is originating from the coronal third of the canal. Because if it is in the middle third or apical third, some microtubes might not be reaching till there. And if it a small file which is fractured in the coronal third also, I can prefer this technique. So this is how you can prepare the microtube. This is the microtube we will get with the etchant, which I have used here to make this, prepare this modified tube. So we have to use a diamond. We have to use a diamond abrasive to cut a hole in this microtube at exactly where the bend starts, and then we can insert a appropriate size of H file just to bypass the broken fractured instrument. So this is the assembly which will be prepared. So this is how it is used in the tooth. Sorry for the noise. Actually, first you should engage the microtube over the head of the file. Then you should insert a H file slowly to engage the fractured fragment, and then you should pull the whole fragment as an assembly in slight clockwise and anti-clockwise motion. So next one more technique is hypodermic needle with an adhesive. So this also uses the same technique where you have to expose 1.5 to 2 mm of the coronal fragment of the file, and then you should select a microtube which fits the this fractured fragment, and then outer part of the microtube is applied with petroleum jelly, and then you should fill the microtube with cyanoacrylate gel or glue or luting GIC. So once you put this into the microtube, you can insert it over the exposed coronal fragment, and you can wait for the material to set. Once the material is set, it can the instrument can be pulled out in a slight clockwise and anti-clockwise motion with a simultaneous pull-out motion. So these are all the techniques which are commonly used for instrument retrieval. So by knowing all these techniques, so I would like to start with my cases. I would like to show you some of my cases. So this is my first instrument retrieval case. It is very close to my heart because not only because it was my first case, because how important it was to retrieve this instrument out of the canal. A 42-year-old female patient reported to the clinic with pain in right lower back tooth region, And on taking radiograph, we can see two periapical radiolucencies in both the canals. And if you see, there is a file fracture in the mesiobuccal canal, and okay, if you see, there is a file fracture in the mesiobuccal canal, and all the canals are underprepared. Okay, after this long webinar, answer me which mechanism because of which mechanism the file might have fractured in this straight canal. So yeah, it is because of torsional fatigue. If you see any file fractured in a straight canal, it is always because of torsional fatigue. Okay, now let's assess the radiograph. So file is of around 3 mm, located in the middle third of the mesobuccal canal, and it is located in the middle third of the canal. And seeing its taper and thickness, we can guess it is a hand file, stainless steel hand file, and it is above the curvature. Actually, there is no curvature; it's almost straight canal. So, what technique you would prefer? So you can answer in the messages. Yeah. So here we can you attempt using most simple and most commonly used technique, that is ultrasonic technique. First, I removed all the GP from the canal orifice. Then I covered the orifices with cotton, and then used all the steps as I explained in the ultrasonic retrieval technique. That is, first using GG drill to enlarge the canal, then used ED16 anti-clockwise motion to expose the coronal 1.5 mm of the file. And once the file is loose, the retrieval is attempted using ET25 with a copious amount of irrigation. And then in 30 minutes, the file is out. One thing you should always keep in mind is that you should always use rubber dam while attempting to retrieve. As when you are using ultrasonic method, you cannot control the file. It might go into other canal. It might jump out and pop out, and it might go into patient throat, and it might put you in more trouble. So you should always use rubber dam. So this file, this is the file which was retrieved around 2.8 mm, and this is the post-op radiograph after instrument retrieval. So there is very minimal dentin loss, and this is after cleaning and shaping. The obturation was done after giving intracanal medicament for 1 to 2 weeks. Okay, this was my second case. As I was highly influenced by ultrasonic technique at this time, a 22-year-old patient was referred from UG clinic for retrieval of file in distal canal of 3/6. When the radiograph was taken, we can see a long fractured file originating from the almost coronal third to 1 mm beyond the orifice. Okay, let's see the clinical picture and let's assess the radiograph. A long file of around 7 mm fractured in a straight canal, and the file is tightly bound in apical third and loose in the coronal third. If you see the canal is very oval and wide, and inner wall is very thin. If you see here, the inner wall is very thin already. So at that time, I was very big fan of ultrasonics. So I started using ultrasonic technique to retrieve. And after half an hour, this was the result. This was my reaction. So a secondary fracture of the file is seen in the middle third of the canal. And I was like, where did I go wrong? Okay, I was wrong since the starting of the case. During my 12th standard, when I was staying with my uncle for preparation of NEET, so my uncle, he's a pediatrician. He used to always tell, if you want to become doctor, you should always study more. There is no other option, because Your eyes cannot see what your brain doesn't know. And if your eyes cannot see, you cannot diagnose. So me, who was inexperienced to choose a right technique at this moment, because of not having adequate knowledge on all factors. So I just stopped the appointment and I put calcium hydroxide intracanal medicament. I gave TF and I sent the patient. I went home, took all the articles, all the books to on file retrieval and read things. So when the patient came for next sitting, I knew I knew right from the starting what I'm doing. So this time the scenario is completely different. So if you assess this radiograph now, the night eye file is around 4 mm, tightly bound in a straight canal, and it is a clear indication for ultrasonic or loop technique. So this time I went in doing staging to loosen the file in the canal, but then I was so afraid to use ultrasonic technique for retrieval because the file was extending beyond the apex. What if there is one more secondary fracture? So once the file was loosened, then one of my seniors helped me in pulling out the fragment from the canal using a BTR pen. So loop technique was used because as it was extending beyond the apex, if there is a secondary fracture, again there is no option left. So this was the X-ray after the instrument retrieval. If you feel like there is a more of dentin loss, it is the canal is already wider. Like canal is always in starting only it is looking like little wider only because of shadow of two canals. So now if you ask me which technique I would have preferred if I have got this case right now. Okay, I would have directly used braiding technique to pull this file out. It would have saved a lot of time for me and also a lot of dentin for the patient. Because if you see the clinical picture, it is a triangular file fractured in a oval canal. So I could have just bypassed the file with two larger K files and then braid it and pull it out. Okay, that's all about that case. Then that case instrument was retrieved and it was referred back for obturation. So this was my luckily this was my next case. A long F3 file in a straight canal, 2 to 3 mm beyond the curvature, 2 to 3 mm, 2 to 3 mm beyond the apex, and originating from the coronal third of the canal. And you can guess it was if seeing the how much it has got extended, you can guess it was referred from the UG clinic. Yes, they're learning. So this time, since I knew the trick, uh, a long file, a night eye file in the wide canal and tightly bound in the apical third, loose in the coronal third. I knew the trick. This time I had all the opportunity to make things right. This time I did not use any ultrasonic. I used only GG drill to enlarge the orifice around this file, and then I directly went in with my two wires. 20H files, they were bypassed and engaged at least 2/3 of the length of the fragment and then pulled out in slight clockwise and anti-clockwise motion. This was the retrieved file. This was the X-ray after radiograph after retrieval of the instrument, and this is the obturation. Okay, this case was referred for retrieval of night eye file from the mesiobuccal canal of 2/6. So the patient had reported back for crown preparation after 3 days of obturation. And in radiograph, they found out that the GP was extending beyond the apex. So they decided to do selective retreatment of mesiobuccal canal. So while retrieving the GP and then removing all the sealer around the dentin walls, the S2 rotary file was broken in the mesiobuccal canal. So if you assess the radiograph, and radiograph. The file is of around here in this radiograph. The file is of around 7 mm, broken in the curved canal. It is extending from coronal third till the apex. So if you see clinically, the file is pressing against the outer curvature, and there is a huge space in the inner curvature of the wall. That is because he had prepared the canal up to F3 in his last preparation, and this time the S2 was fractured. So there is a huge size gap. So this came to my advantage. So what I did was I used ultrasonic to de-roof this segment and expose the file head completely. Then I used the endodontic explorer to free the file head from this outer curvature. This file head from the outer curvature, and then once you free the file head from outer curvature, I used the 15K file and bypassed it in the outer curvature, and then I went in with 20 number K file in the inner curvature to engage the fractured fragment tightly. So once the fractured fragment is engaged tightly, I used the I used to pull whole assembly in slight clockwise and anti-clockwise motion, and the file is out. You can see the file is how the file is out in the how the file is out. Then this is the radiograph after instrument retrieval, and then it was referred back for obturation, and this is the obturation. Okay, this case was referred for retrieval of fractured H file in the mesiobuccal canal of mandibular molar 3/6. So before taking radiograph, I just removed the TF and irrigated the canal to flush out all the calcium hydroxide. So then when I tried to check in which canal the file is fractured, to my surprise, I could achieve patency in all of the 3 canals. So then I went to take radiograph. In first radiograph, it was looking like bit like calcium hydroxide in the canal. But then when I irrigated again and visualized it under the microscope, I could see a file head in the mesiobuccal canal struck in the isthmus of the canal. So now assessing the radiograph and clinical situation, it is a long H file extending from just below the orifice till the middle third. Whole file is extending above the curvature. So as there was a lot of space adjacent to the file, I tried to use a braiding technique again because it saves a lot of time actually. But I could not succeed in getting a file in between the file and this isthmus because it was the file was tightly threaded into the isthmus. So then next, as I failed to put a file in between the file and the isthmus, I went in with ultrasonic tips. So I trough in the inner curvature in between the isthmus to loosen the file from the isthmus. So one advantage of having isthmus during file fracture is that it is easier and safer to remove dentin at the isthmus between the 2 canals. So it is very safer and easier to remove the dentin in the isthmus because there is a very adequate amount of dentin is present there. This isthmus is also present in maxillary premolars, where also we can take advantage of this isthmus during file retrieval. So once I loosen the file with ultrasonic tips, I use the you can see this access cavity. There is a file which is loose now, but still it is not coming out with ultrasonic technique. So now I went in with the loop. So the loop was prepared using microtube and thinner diameter of wire, and then it was engaged in the canal and rotated and pulled. So when I saw this fragment stuck in the loop, I was not so happy because the length of the file was a little bit smaller than what I had expected. So I went to took a radiograph to see the if there any secondary fracture or not. So when I took the radiograph, I could see a small radio opacity in the middle third of the canal. So then I went in with ET25 to trough around the smaller fragment with minimal dentin removal to retrieve it within 3 to 5 minutes. So this was the smaller file which was retrieved, and then this is the access. This is the radiograph after instrument retrieval. So here also you can see there is very less uh, dentin loss. So this was the obturation using a bioceramic sealer. So this will be the last case, and this was the one of the my easiest file retrieval I have done till now. So a patient was referred for retrieval of broken H file as we are almost 57 minutes. So I have very less time left now. So patient was referred for retrieval of broken H file from the palatal canal of the 27. On taking clinical radiograph, on clinical on taking radiograph and clinical assessment, the file was struck within the GP of the palatal canal, and it was completely within the GP. So I used ET25 in conjunction with GP solvent and removed the GP around the file using the very thin ET25 file. And once the file became loose, I flushed the canal with the irrigant and activated the file to retrieve the file. So you can see the radiograph after file retrieval, and this was the small H file which was broken. But still you can see it is extending from coronal third to almost middle third of the canal. So this is one trick you can use while retrieving the instrument book broken within the GP. If you use one more H file, and again it might get stuck, or it might get stuck in the canal wall. So there is more chances. So, but all of this should be done under always should be used under microscopic vision, or at least loops. Otherwise, it is not so easy to get to visualize all these things. So these were some of my best cases, which was I felt will be helpful for you people to relate and learn some of the important and most commonly used instrument retrieval techniques. So let's answer the question of this webinar. So what is the best predictable technique for file retrieval? So if you see, all of these techniques mentioned become predictable if we choose them very wisely. It all comes with knowledge and experience. So assessing the radiograph and clinical condition before the retrieval is the key to success of the file retrieval, as equally as to the retrieval procedure. You should thoroughly assess the clinical and radiographic situation of the file and the canal. In the end, I would like to remind you that our college is hosting a ADAI conference in February this year. So if you have not registered, you can register, and don't forget to ping me on Instagram so that we can meet. I'll be so excited to meet you all in person. So, and don't forget to follow me on Instagram, where I'll be posting more of cases frequently, and keep following Safe Dental updates for more helpful webinars. Thank you. Thanks to Safe Dental updates.
Thank you so much, sir. So we're just going to have a short question answer session. We're not going to take a lot of time, just because time is very short.
Yes, sir.
So we'll just accept just a few questions, and I'll just request the audience to post any questions which is relevant to the topic only, not regarding about any other topic. Please, I just want to request only the audience just to post questions which is just relevant to the topic. So I'll just point out a few questions, And with that, we'll just wind up this session.
So okay, someone has asked, can you explain which ultrasonic tips you have used? So for troughing, I'll always prefer ED16, and for retrieval attempt, I'll use a more thinner files like ET25. So these thinner files you can use at higher power setting, because when they are in the they can be used at higher power setting. Because when you're doing retrieval attempt, you are irrigating the canal and you are flushing the canal with irrigant. So the fracture of this ultrasonic tips becomes reduced when you use it in with irrigants. So these two tips I use usually. So what about fractured instrument in apical third? So when the instrument is fractured in the apical third, most of the times we will prefer either bypassing or obturating within the uh, canal, because if you try with ultrasonic technique, there is a lot of dentin which is you are going to losing. But it is always depending on the patient symptoms. If patient is having continuous pain, even like after uh, if patient is having continuous pain, you might have to go and do a surgical intervention also, because in apical third the retrieval becomes more tougher as compared to coronary and middle third. But you can try with thin when if it is very short, you can try with thinner ultrasonic tips always.
Okay, I think there's one question regarding about how much is the minimum magnification required to locate the file separated
Okay,
instrument.
if you can see the first 2 3 cases which I shown, I had done it under the loops which had around 3.5 magnification, and later on I use microscope which will give me around 8x. It has 8x to 12 up to 12x I can magnify, but I'll use around 8x magnification. So what about the file tightly bound to the coronal third of the canal? So as a first try, you can use the ultrasonic technique, or if you can bypass, you can go in with, if it is very short, then you can go in with modified tube method. It is very easy using modified tube method when the fracture is near the orifice, and the you can bypass with at least 20-25 number file. So you can bypass, pull it as an assembly. So it will come out. So can you suggest? Well, okay.
Yeah.
Yeah.
Okay. So
Someone has asked if a brooch is broken about 3 mm in the central incisor. So there is one technique for that. You should use one more brooch with a little swipe of cotton, and you go with the cotton, and once it is engaged, you can pull it out. That is also a technique for retrieval of a brooch. Someone is asking, all these procedures should be done under microscope. What if one doesn't have? Yeah, it is mostly preferred to use magnification, and you cannot visualize things like very minute things in your naked eye without magnification, obviously. So you should always use magnification, at least loop. Loops are also not enough when the fragment is in middle third, or like 2 to 3 mm beyond the orifice. Okay.
Okay, I guess we will wind up the session, sir. So if any other questions are there, we'll try to rectify it in any of the social media platform or in our Instagram platform.
Yeah, you can always contact me in the Instagram, and I'll be available.
Okay, sir. So thank you so much, sir, for sharing your knowledge and expertise when it comes towards the file retrieval. And surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So thanks to all the doctors for patient listening and for your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So
Thank you everyone for attending.
once again, thank you so much, sir. It was a wonderful and informative discussion.
Thank you, sir. Thank you for making this possible. Thanks for inviting me for this lecture.
Yes, sir. So we really appreciate your valuable time given for us for this series episode. So please do check out Sir's Instagram page where you can appreciate Sir's clinical works and do follow him. And to know more about our upcoming webinars and workshops, please do check out our Facebook and Instagram pages. And if anybody has missed out our previous webinars, you can do check out our YouTube channel as well. And please don't forget to subscribe. So thank you all and have a great night.
Thank you. Thank you, everyone.